Hello everyone, we're from the group B9 and today we want to present about our student project with the title Pulmonary Embolism. So here are the members of our group. There are 12 people in our group and now we will start our presentations.
Hello everyone, my name is Putusan Gitani Rajanari and the last three digits of my student number are 049. I'm here about to explain the pulmonary embolism background. So pulmonary embolism or PE is a pathological condition due to obstruction caused by blood clot. It can come from vein thromboembolism or VTE, which come from the deep vein thrombosis or DVT. PE have a high incidence rate of 10 million people per year. PE has a high mortality rate of approximately 300,000 people in the USA every year. In Indonesia itself, PE has a mortality rate of 15% with an incidence rate of 23 per 100,000 people. PE is said to be a life-threatening emergency because it is asymptomatic, with about 20% of people experiencing venous thromboembolism or VTE dying within a year. Treatment is really important because 30% of PE untreated patients die compared to the treated one that have only 8% cases that is dying. Fortunately, there are opportunities for primary, secondary, and primordial prevention for PE. Seeing the high number of deaths and the incidence rate of the PE, further review for the pulmonary embolism, especially those related to the DVT and VTE, is needed to broaden our horizons in order to minimize this. That's all from me. The next slide will be presented by my friend. Thank you.
Hello, my name is Nyoman Gede Wilagunardi Paramarta and my last three-digit number is 180 and I'm going to explain about the definition and epidemiology of pulmonary embolism. So, pulmonary embolism is a serious and potentially life-threatening condition characterized by a blockage in the pulmonary arteries which supply blood to the lungs. This blockage is most commonly caused by blood clots that have traveled from other parts of the body, particularly from the deep veins in the legs, a condition known as deep vein thrombosis. The consequences of PE can be severe, leading to symptoms such as sudden shortness of breath, chest pain that may worsen with deep inhalation, rapid heartbeat, dizziness, and coughing up blood. Pulmonary embolism and deep vein thrombosis pose significant public health challenges, with 300,000 to 600,000 cases of PE occurring annually in the US. The incidence of PE varies by region, from 0.039 per 1,000 people in Hong Kong to 1.15 per 1,000 in the US. Venous thromboembolism or VTE is more frequent diagnosed in high-income countries due to better diagnostics and awareness. However, many sudden cardiac deaths may be due to undiagnosed PE. Age is a key factor, with PE rates rising sharply in individuals over 75, reaching over 500 per uh, 100,000. In Indonesia, the incidence of deep vein thrombosis among medically ill patients is high, with multicenter studies showing rates of 37.1% to 40.3%. Healthcare disparities across regions highlight the need for better data and awareness. Obesity and prolonged immobilization are major risk factors, aligning with global trends. Pulmonary embolism contributes significantly to in-hospital mortality, with 10% of PE patients dying, particularly with those with pre-existing conditions. So that's all for me. Thank you.
Thank you for the opportunity. My name is Joanna Alisata Nuraharja with the last three digits of my student number 079. This time, I'm going to explain about the etiology and risk factors of pulmonary embolism. Now, the main cause of pulmonary embolism is a history of prior deep vein thrombosis or DVT in the lower extremity. Other rarely found etiologies of PE are air embolus, fat embolus, DVT from the upper extremity, and tumors. According to its origin, the risk factors of PE can be divided into genetic, such as family history, factor V latent mutation, etc., and acquired, such as prolonged immobilization, major trauma, malignancy, smoking, etc. That is all from me. The next will be continued by my friend. Thank you.
Hello, my name is Matthew Gavertin with the last three digits of my student ID 003. Victor striate contains hypercoagulability, venustasis, and endothelial injury. These primary factors contribute to the formation of blood clots or thrombi in the deep veins of the legs or pelvis. This is what we call a deep vein thrombosis. It can either stay or it can dislodge and then travel through the bloodstream. It travels through IVC and then the right AV of the heart, and then it lodges in the pulmonary arteries or arterioles. This is what we call a pulmonary embolism, which will result in the obstruction of blood flow. Next slide. When there are blockades in the pulmonary arteries or arterioles, many physiological changes will occur. One of those changes will be a decreased perfusion in the lung parenchyma and an increase of dead space ventilation. This will result in a ventilation perfusion mismatch and ultimately increase hypoxemia because lungs cannot properly deliver oxygen to the blood. Other than that, pulmonary embolism can increase inflammatory response. The response will result in the increase of the membrane permeability between alveoli and capillaries. These changes may facilitate fluid accumulation in the lungs, which can lead to the thickening of the membrane, ultimately resulting in the impair of gas exchange or diffusion of oxygen and carbon dioxide in the lungs. That's all from me. Next slide.
Hello everyone, my name is Igusa Prabhatasi Kirana and the last digits of my student ID numbers are 212. So in this presentation, I will be explaining about the hemodynamic effects of pulmonary embolism. So as stated in the previous section, the primary substance linked to 19% of pulmonary embolism is thrombus, which is regulated by a multi-step of coagulation cascade. This coagulation cascade involves multiple factors and can be triggered by multiple factors, such as plasma hypercoagulability, blood flow changes, and dysfunction of the endothelial cells. The right ventricle's thin and walls and lower contractility in comparison to the left ventricle are due to the low resistance of the pulmonary vascular system under normal circumstances. Furthermore, because of the low right ventricular mass, the right ventricular contractility reserved to pressure volume overload is modest, leaving the right ventricle susceptible to an abrupt increase in right ventricle afterload, which can happen in acute PE. So, in pulmonary embolism, vasoconstriction and pulmonary arteries will occur, and this will increase the pulmonary pressure. So, this increase of pulmonary pressure will then decrease the stroke volume and causes right ventricular dilatation. And this will then cause right ventricular overload, which will increase the stress on right ventricle myocytes and decrease coronary perfusion on right ventricle, which eventually will lead to right ventricle failure. That's all from me. Thank you.
Greetings, my name is Tracy Odela Jiralia Kema with my student number 115, and I'll be explaining the clinical signs and symptoms. Diagnosing pulmonary embolism or PE may be challenging as clinical signs and symptoms are variable and nonspecific to PE, and even asymptomatic in some cases. Common symptoms are chest pain, syncope, cough, shortness of breath, hemoptysis, and dyspnea. Chest pain are usually caused by pleural irritation from a distal embolism that results in pulmonary infarction. Dyspnea are sudden onsets, but can also progress gradually and are characterized by sharp pain triggered by inspiration. Hemodynamic instability is rare but can happen, and it indicates a large PE with significantly diminished hemodynamic reserve. Severe PE may manifest in cardiac arrest and hypotension. Acute right ventricular failure manifests in shock, cyanosis, peristernal lift, and jugular vein distension. That is all for me. Thank you.
Hello everyone, my name is Farel Amaramanik with the study of student number 243 and I'm going to talk about the physical examination and diagnostic tests. The first one is pretest probability. The Wells score and Geneva scores are commonly used to assess PA risk and reduce the need for invasive testing. The pulmonary embolism rule-out criteria or PERC can also exclude PA in low-risk patients. avoiding further testing if all 8 criteria are absent. Second one, biomarkers. D-dimer testing helps rules out PA, especially in low to intermediate risk patients. Though sensitive, it lacks specificity and may be negative in some suspected cases. And then ancillary studies. Arterial blood gas analysis and electrocardiogram may show normal result or suggest PA through signs like sinus tachycardia or atrial arrhythmia. Chest radiograph with unexplained hypoxemia should prompt further imaging like chest CTA or VQ second. And then imaging studies. CT pulmonary angiography or CTPA is the primary imaging tool for PA diagnosis due to its accuracy. A ventilation perfusion scan can be used when CTPA is contraindicated. Compression ultrasound helps identify deep vein thrombosis as a potential source of the emboli.
Alright, thank you for the opportunity. My name is Ryan Aditya Putranto with the last three-digit number is 094. I'll explain to you about the differential diagnosis of pulmonary embolism or PE and how to differentiate them. The first one is acute myocardial infarction or AMI. We can differentiate them by ECG finding, cardiac enzyme, and imaging. The ECG findings, AMI shows characteristic change like ST elevation or new Q waves, whereas PE may show non-specific ECG change like sinus tachycardia. Cardiac enzymes, elevated troponins are more specific for AMI, though they can also be elevated in severe PE due to right heart state. The imaging, coronary angiography or cardiac catheterization can confirm AMI, while a CT pulmonary angiogram or CTPA is used to confirm PE. The next differential diagnosis is pneumonia. We can differentiate with pulmonary embolism by chest X-ray, blood test, and sputum culture. The chest X-ray pneumonia will show localized lung infiltrates, whereas PE may show non-specific findings or feature like wedge-shaped infarcts. The blood test increased white blood cell count and elevated inflammatory markers like CRP or procalcitonin are more common in pneumonia. Sputum culture identifying a bacterial pathogen supports pneumonia. The last differential diagnosis is pneumothorax. We can differentiate them from PE by physical examination. Pneumothorax often present with decreased or absent breath sound on the affected side and hyperresonance to percussion. And we can differentiate them too by chest X-ray. Clear evidence of air in the pleural space and lung collapse distinguish pneumothorax from pulmonary embolism. Alex, that's all from me. Thank you.
Hello, my name is Kadek Bintang Aristia Putri with my last three digits of my student number is 056 and I will explain about the treatments of pulmonary embolisms. The course of the treatments is anticoagulants and also depend on the patient's clinical conditions. Initially is focusing on ensuring adequate oxygen supplies and hemodynamic stabilizations. And all of the treatments of anticoagulant can be seen on the tables. And the kind of anticoagulant that can be used is dabigatran, apisaban, edosaban, and rivaroxaban. And all of the combinations could be used for the non-vascular atrial fibrillation prophylaxis, venous thromboembolism treatments, and venous thromboembolism primary prophylaxis. Thrombolytic therapies is typically reserved for patients experiencing shocks or significant cardiorespiratory distress. Tissue plasminogen activators or TPA is the most commonly used thrombolytics, usually given as a 100 mg infusions over 2 hours. TPA is also administered in catheter-directed thrombolysis at lower rate of 0.5 to 2 mg per hour for 2 to 15 hours. That's all from me, and the next slide will be presented by my friend. Thank you.
Hello, my name is Patricia Arlinjatan and the last three digits of my student number is 171. Now I'm going to explain about the management of pulmonary embolism. The management of PE involves a long-term strategies through reduced recurrence risk through lifestyle changes, monitoring, and education. Effective management is crucial to prevent complications and improve patient outcomes. The first one is the initial management that are focused on supportive measures, including supplemental oxygen for patients with oxygen saturation below 90% and mechanical ventilation for those in respiratory distress. For patients suspected of having PE who are hemodynamically unstable, immediate imaging such as computed tomography, pulmonary angiography, or an echocardiography is recommended to confirm the diagnosis and assess the right ventricular function. As for the surgical and catheter-based intervention that are the option for treating larger clots that pose an immediate threat to life. The first one is the surgical embolectomy is typically considered when thrombolysis is either ineffective or contraindicated.
And the second one is catheter-directed therapies, including ultrasound-assisted thrombolysis and suction embolectomy. Can also be ineffective and offering a lower risk of complications compared to an open surgery. As for the long-term treatment, anticoagulants are typically prescribed for at least 3 to 6 months, depending on the underlying cause and risk for recurrence. Patients with transient risk factor may discontinue therapy after this period, while those with ongoing risks such as cancer might require extended anticoagulation. So overall, the management of PE requires careful consideration of individuals' patient factors and ongoing assessment to mitigate risks associated with treatment and prevent recurrence. Regular follow-up is essential, and monitoring for complications like chronic thromboembolic pulmonary hypertension, which can develop in about 5% of patients following a PE. That's all for me. Thank you.
My name is Jelly Fitri Atata Ginting, but the last 3 digits of my student number is 140, and first I will be explaining about the complications. There is the post-pulmonary embolism syndrome, which is the persistent dyspnea within 3 months of diagnosis, despite getting the anticoagulants. Next, the more extreme end, chronic thromboembolic pulmonary hypertension, which shows mean pulmonary artery more than 25 millimeters of mercury, and there's the thrombotic pulmonary vascular obstructions. And the test that should be done is, for example, ventilation perfusion lung scan, which shows mismatching ventilation perfusion defect, and catheterization of right heart and pulmonary angiography to assess the degree of the pulmonary hypertension. And next, there's the recurring thromboembolism, which the anticoagulant treatment should be continued. Explaining about the prevention of pulmonary embolism. First, they can be given anticoagulants to prevent blood clots for DVT patients, and to prevent the risk of DVT by lifestyle changes, for example, weight loss, routine exercise, preventing prolonged sitting or standing, and they can also be given vena cava fillers, which manage the proximal DVT when a patient is unresponsive to anticoagulant treatment and high-risk bleeding. It prevents blood clots from reaching the heart and lungs, so preventing the pulmonary embolism. And that is all from me. Thank you.
Hello, my name is Ananda Aulia with 3 last digits of my student ID number is 015. Now I'll present you about the conclusion. Pulmonary embolism or PE is a serious condition where a blockage in the pulmonary arteries, typically from blood clots originating from deep vein thrombosis in the legs, leads to severe complication. Affecting 300,000 to 600,000 people annually in the US, PE is associated with risk factor outlined in first triad, which is hypercoagulability, venostasis, and endothelial injury, although fat, air, or tumor emboli can also be causes. PE disturbs gas exchange, causing hypoxemia by impairing oxygen delivery and increased pulmonary vascular resistance, which strain the right ventricle, potentially leading to heart failure. Diagnosis is challenging to variable symptoms like chest pain, cough, and shortness of breath. Tools such as the Wells and Genevieve score, D-dimer testing, and CT pulmonary angiography aid in assessment and confirmation, while blood gas analysis and electrocardiogram provide further support. Differentiating PE from other conditions like acute myocardial infarction, pneumonia, and pneumothorax is crucial for proper treatment. The treatment focuses on patient stabilization, which is using thrombolytic therapy such as tissue plasminogen activator, reserved for severe case, and anticoagulant prescribed for 3 to 6 months. Long-term follow-up is necessary to monitor complications like chronic thromboembolic pulmonary hypertension, which occurs in about 3% of patients and requires lifelong anticoagulant. That's all from me. Thank you.
So that's all for our group presentations, and thank you so much for watching.